Good afternoon, everybody, and welcome to this afternoon's webinar. My name is Debbie Harvey. I'm a GP and the Associate Medical Director at Cheshire and Merseyside Cancer Alliance. Next slide, please. The webinar will be recorded, and a copy of the recording, along with the slides, will be published on the Cancer Academy. The QR code is right on the screen there for you. The audience cameras are turned off and the microphones are muted, but please share any comments or questions in the Q&A box at the top of the screen and we'll answer as many of those before the end of the webinar. Next slide. We have a number of brilliant speakers joining us this afternoon. All of them great advocates of early diagnosis in pancreatic cancer and really keen to share their knowledge with you. Next slide. So the agenda today is we're looking at pancreatic cancer with symptoms and presentation, really important in primary care. We'll also be looking at new onset diabetes and weight loss, referral pathways, how MDTs work and surveillance follow-up. We'll also be looking at patient management after surgery, and at the end we'll also have some Q&As. We'll also be asking you to evaluate the webinar this afternoon. Next slide. So it gives me great pleasure to hand over to Mr. Peter Satsmari, General Consultant and Pancreatic Surgeon. Thank you, Peter.
Thank you, Debbie. Good afternoon. My name is Peter Satsmari, and I would like to welcome you all to this webinar on pancreatic cancer for primary care. I'm really pleased to have so many of you logged on today, as it shows a desire from all of us to improve care for patients with pancreatic cancer. This month is Pancreatic Cancer Awareness Month, and it is here to remind us that despite all progress, pancreatic cancer remains the deadliest common cancer, with half of people dying within 3 months of diagnosis. We have a packed program today which will provide you with an overview of modern pancreatic cancer care, highlighting the areas of excellence we have here in Cheshire and Merseyside. Next slide, please. Overall, pancreatic cancer is a disease of older patients with a peak incidence of 70 to 74 for men and 75 to 79 for women. Nevertheless, sporadic pancreatic cancers can and do occur in patients in their mid to late 30s. As with many other cancers, the incidence of sporadic pancreatic cancer has been rising steadily since the early 2000s. Next slide, please. Survival for all comers remains dismal. This is our local Cheshire and Merseyside data, and you can see that amongst all cancers, pancreatic cancer has the lowest rate of 5-year survival at around 8 to 10%. The only aspect of this chart that provides me with some joy is that the 5-year survival of pancreatic cancer is slightly better in Cheshire and Merseyside than the rest of England. This is despite having some of the most deprived populace in England, with many districts within Liverpool, Widnes, Warrington and St Helens in the top 1% of health disability deprivation. I have to highlight this, not to pat us all on the back, but to say thank you to all of you who remain vigilant and refer your patients in a timely manner so that we can offer them effective treatment. Next slide, please. As with all cancers, there has been some improvement in survival in pancreatic cancer over the past 20 years. And you can see, sorry, slightly small, but third on the left, pancreas cancer also has improved somewhat in terms of 5-year survival over the last 20 years, but we have a long way to go. Next slide, please. Many of you will have seen the patient-directed infographic from Pancreatic Cancer UK, highlighting some of the symptoms to look out for. It is an easy guide for the lay public to look out for some of the more common symptoms and can be ordered as posters for your practice waiting rooms, for example. I do find it a little disconcerting because you will of course recognise that if you discount jaundice as the one true hard sign, there is not much to go on, and reading through the symptom lists makes me worry every time about my pancreas. But it is the persistent change that might highlight something is not quite right. And please allow me to introduce Kelly at this stage, one of our 2 patients who will share some of their stories with us today.
I was diagnosed in September 23 with pancreatic cancer. I think I just felt, if I'm being honest, like they'd made a mistake. I thought this was going to turn out to be nothing. And I can't say I went into, a spiral of worry or anything like that, because for me, I didn't. My symptoms, I'd woken up one night with what I thought was a bit of indigestion. It was sort of an upper stomach pain. That subsided. I was left with a few days of nausea. Once that went, I got really, really severe itchy hands and feet. And I thought, that's not right. So I went to the doctor, they sent me for a blood test, and they got back in contact with me and said that my liver levels were really, really high. So they wanted an ultrasound. So they sent me for an ultrasound on my liver, which turned out to be fine, but there was a blockage coming from the tumour on the pancreas, which had obviously raised the alarm. My referral was very quick. It did seem like it was just one scan and one appointment, one after the other. There wasn't really any big wait at all. Obviously, it is a slightly worrying time, but I didn't have a lot of time to sort of ponder on anything, because it was one scan, one appointment after the other. And like I say, there was always somebody there if I needed to speak to anybody. If anything, they were getting in contact with me constantly. To the point where sometimes I'd think, oh, it's the hospital again. And I pretty much knew as much as I could physically handle at the time. During my treatment, all the members of staff were absolutely amazing. From the staff at the Royal to my doctors, to the team at St Helens, everybody was amazing. But one member of staff that stood out to me the most was my pancreatic nurse, and her name was Sophia. I always felt I could speak to her. She was really understanding, and yeah, she's the one who stood out to me the most. In regards to how I am now, I'm fit and I'm well. It has gave me a completely I'm not the person I was before. It's gave me a massive health anxiety, which I didn't ever think had happened to me, but it did. The only drawback for me throughout it all has been I don't feel, since all my treatment is finished, I don't feel like I'm seen enough. I don't get regular scans, I don't get regular blood tests, I don't get regular check-ins unless I present them with a problem. That would help me massively in regards to my state of mind. I'm only 2 years in, and I'm 50% reoccurrence rate for the next 5 years. So in my opinion, I think it should be a general thing that even if it's just once every 6 months, just to keep an eye on things, make sure there's no changes. But unless I present a problem, there's nothing like that for pancreatic patients. Mental health wise, I've not really been given any support now. Initially, I probably would have said, no, I don't want it. Because you do want to put it all behind you and move on. And I thought I would be able to, but it hasn't been that easy. So maybe if it was offered to me now, I probably would do maybe a little bit of talking therapy. I would like to meet other people like me. There's plenty of pancreatic patients out there, I get that, but I'm yet to find anybody the same age as me. And they're the ones that I know I can resonate with.
Thank you, Kelly. Kelly's story is a perfect example of how a patient might present and how we might interpret and investigate the symptoms mentioned earlier. Kelly also was in her mid-40s when she first presented, so serves as a reminder that even though pancreas cancer is predominantly a disease that appears later in life, it can occur a lot earlier than many suspect. NICE has provided some guidance in the form of NG12 relating to recognition and referral of suspected pancreatic cancer in primary care. This suggests to refer anyone over 40 with jaundice, and I would add painless jaundice, and arrange a direct access CT scan if over 60 with weight loss and any of diarrhea, abdominal or back pain, nausea, vomiting, or new onset diabetes. This last one deserves further mention. Next slide, please. Pancreas cancer and diabetes are closely linked. Patients with type 2 diabetes are at increased risk of developing pancreatic cancer throughout their life. Pancreatic cancer itself produces a form of diabetes now called type 3C, or pancreatogenic diabetes, in which insulin and glucagon production drops, peripheral insulin resistance is normal or a little high, and patients experience both extremes of high and low blood sugar. Around a third of patients presenting for pancreas cancer surgery have undiagnosed diabetes prior to their procedure. And of course, surgical removal of part of their pancreas further predisposes them to post-operative diabetes. We can use this relationship between diabetes and pancreatic cancer to our advantage when making a diagnosis. And I would like to introduce Professor Ethna Costello from the University of Liverpool as one of the leading scientists in this field to tell us more.
Thank you. Good afternoon, everybody. Next slide, please. So since I've been working on pancreatic cancer for 25 years, and in that time, all of the improvements, or most of the improvements for patients, has come for patients who have operable pancreatic cancer. So that has been a big incentive to us as scientists in Liverpool to go for earlier detection and move people out of the spread to distant organs or spread locally categories into operable. Next, please. So anybody who has a family history of pancreatic cancer, has germline mutations, pancreatic cyst, or hereditary pancreatitis, is eligible for screening for pancreatic cancer. And that accounts for about 15 to 20% of people. However, next, please. For people who are in the remaining 80 to 85% of pancreatic cancer cases, there is no screening test that allows earlier detection. And that's the group I want to talk about, because in that group, there's the high-risk group of new onset diabetes. And it brings me to that. Next slide, please. So just to mention a couple of things about the relationship between pancreatic cancer and diabetes. We did a study checking the diabetes status of 166 patients who were undergoing pancreas surgery for operable pancreatic cancer between 2016 and 2020. And we found that 59% of those individuals at preoperative assessment had disrupted glucose regulation. So that was mostly in the form of new onset diabetes. 13% had long-standing diabetes, 11% impaired glucose regulation, but most of that group had new onset diabetes, and just over 1 in 3 of those patients didn't know they had diabetes until preoperative testing. It probably speaks to how rapidly diabetes progresses in these individuals, and also that perhaps people aren't getting regular tests for diabetes, aren't presenting to their GP for regular tests if they're well. Next slide, please. So here's how it looks. I want to sort of take a look from the vantage point of a pancreatic cancer patient, but also from the point of view of somebody who's been newly diagnosed with diabetes. First of all, let's look at a pancreatic cancer patient. So the red line on this graph shows the moment of pancreatic cancer diagnosis. If we go back in time then and ask what's been going on in the months and years prior to that diagnosis, we now know that hyperglycemia begins to occur, and patients begin to experience hypoglycemia 3 years before their cancer diagnosis. And that hypoglycemia tips into diabetes on average at 8 months prior to, sometime between 6 and 12 months prior to diagnosis. It's variable from one individual to another, but on average 8 months prior to their cancer diagnosis. Weight loss, very mild weight loss, begins 18 months prior to a cancer diagnosis. So there are things going on in an individual with pancreatic cancer. And we see this gap between the moment that diabetes is diagnosed and the moment cancer is diagnosed, that current gap, as a window of opportunity to look for ways to detect pancreatic cancer earlier. Next slide, please. So why don't we just screen everybody who is newly diagnosed with diabetes, who's over the age of 50, because they are the high-risk group for pancreatic cancer? And the answer is, given the prevalence of pancreatic cancer in that group, it's around 0.8%. And that's indicated by the little red figure compared to all the green ones. So currently, with the fact that it's a low incidence in that population, and the fact that we do not have the screening tools needed, It's not feasible. The accuracy, we don't have the accuracy of screening tests needed. It's not feasible to screen individuals with new onset diabetes for pancreatic cancer. So we must select those most at risk. And in the United States, the way that the proposed way of doing that, and it's being tested at the moment, is to use a score, an algorithm that measures three things: a change in fasting glucose over the year before diabetes onset, a change in body weight over the same period, and the age at diabetes onset. Now, that works well in the United States because in that healthcare system, many people have health insurance, and they are obliged once a year to have health checks in order to keep up with their health insurance. However, it's unlikely to work as well in the UK, and we know that there are a lot of missing data, probably because some people, if they're well, don't attend their GP that often. So it's that left window data, or the data from 1 year ago, that might be missing. So we have taken a different approach. In the UK, we probably need to either get better at attending our GP or take a different approach that suits our population. And the way we've been looking at this is looking at a biomarker that could distinguish type 3C diabetes from type 2. And so let me just explain that. If we take all of the people that were all coloured green a moment ago, so all of the people on the chart at in front of us right now have been diagnosed with type 2 diabetes, but actually 10% has undiagnosed type 3C, which is diabetes secondary to pancreatic disease. So most of them will have pancreatitis, but at least one we know 0.8 to 1% of those has pancreatic cancer. They already have pancreatic cancer. That's what's causing their diabetes. Next slide. So if we could find a way, an easy test that was implementable at the moment of diabetes diagnosis that could distinguish type 3C from type 2 diabetes, we could then next have a way to it would be feasible now with that smaller, highly enriched group for people who are more at risk of pancreatic cancer. It would be feasible to screen those individuals. Similarly, and you can keep going several next, similarly, if there was a biomarker that could screen for pancreatic cancer, as cancer-specific biomarker, that would also work. So how are we going to get to a point where we can screen people with new onset diabetes for pancreatic cancer? I'm just going to leave you with a little bit of an update on the science we do. We were funded by Cancer Research UK to build resources that would help us understand that population. So the first thing we're doing next is we have a program of activity. One of the major parts of that program is to build a cohort of individuals over the age of 50, newly diagnosed with diabetes, so within 6 months of a diagnosis of diabetes, and follow them every 6 months for 3 years, getting blood samples and also questionnaire data from them. We're also looking at cost effectiveness. And so next, what we're doing here is that we have currently got 824 or so participants registered, with 32 sites in the UK and 60 affiliated PIC sites collecting for us. Next. And just I'm going to leave you with some of the progress we have made. We believe that it is possible, based on blood proteins alone, to distinguish type 3C from type 2. And we have a couple of biomarkers we think can already do it. Next, we have the possibility of going even deeper into the number of blood samples, number of proteins in blood that we can test. So when we did our first analysis, identifying the 2 biomarkers on the left, we only had the possibility of looking at about 400 proteins in blood. Now we can quantify 7,500. It's going up all the time. And so looking for perhaps even better ways to distinguish type 3C from type 2. And our cost benefit analysis tells us that it becomes cost effective if we do a first test for type 3C diabetes and follow up with a cancer specific test. So I'm going to stop there because I think I'm out of time. But just to say thank you on my next slide to all of my team and the colleagues at Liverpool and the UK EDI, that's our UK programme, our collaborators, and of course the participants, the people, patients who give their time, their blood samples and their data to us, so that we can try to understand how best to tackle the question of how to detect pancreatic cancer more easily in people with new onset diabetes. Thank you very much.
Thank you, Ethna, and I'm sorry for making you do all of that in the short time we had available. Right. But no, thank you. Next slide, please. We have seen the national NG12 guidelines, but I just wanted to highlight these, which are the local Cheshire and Merseyside referral policies, which mirror the national guidance. In Cheshire and Merseyside, we ask for all patients with new onset painless jaundice, which is the most straightforward first point, but also the combination of weight loss and new onset diabetes in over 50s that should trigger direct access referral for a CT scan. And we've just heard some of the rationale behind that. More and more of the resectable cancers referred to our MDT have come through this route already. Next, please. Other than imaging, I would just like to briefly mention serum biomarkers. The only serum biomarker currently in clinical use in the UK is CA19-9. This is a cell surface polysaccharide present on the surface of biliary epithelium and is elevated in serum and plasma of around 80% of patients with pancreatic ductal adenocarcinoma. Patients without the blood group Lewis alpha and beta antigens lack the enzyme required to make CA19-9, which accounts for about 10 to 15% of the population. So these will never have an elevated CA19-9. Injury or pressure on ductal cells also releases CA19-9, so levels increase in jaundice, in stone disease, or benign strictures. For these reasons, it can be useful as a tool to follow patients with known cancers and other pancreatic pathologies, but should never be used in a diagnostic setting. Many other biomarkers are being tested in trials, but none are thus far used in routine clinical practice. Next, please. Pancreatic cysts could easily fill their own webinar, and I only mention them here as we will investigate some of them by sampling cyst fluid, and you may see tumour markers including CA19-9 and CEA from fluid samples on your ICE reports. These should only be interpreted by the MDT, and it can be entirely normal, sometimes even reassuring, to see a CA19-9 in the several thousands. Please be assured that we are following these patients up and we will discuss their results with them directly. Next, please. The Liverpool Pancreas Unit is a tertiary referral unit for 19 hospitals, which includes 3 in North Wales and 1 on the Isle of Man. We cater for a population of over 3 million people and accept referrals straight from GPs as well as secondary care providers. We are one of the largest dedicated surgical and oncology units for pancreatic cancer in the UK. Next, please. This is probably too small to read, but it highlights the spread of referrals we received only last year, including 122 directly from GPs. With that, I would like to introduce Steve Kelly, our other patient, who will share his journey with us and lead us straight to our nurse consultant, Phil Whelan, who is the backbone of our MDT service.
Hi, I'm Steve Kelly. I was diagnosed with pancreatic cancer in October 2018. I was at a work-related sports event down in London in July of 2018. Because a long story short, I slipped and fell and cracked a rib. And over the next sort of 4 to 6 to 8 weeks, it wasn't really healing as well as I thought it would have done. So I've been going to doctors over the course of 3 or 4 weeks, getting bloods checked and done, make sure everything's as it should be. And the blood tests gradually are getting worse over the course of 4 to 6 weeks, accumulating in being admitted into Western Hospital early October of 2018. And a number of tests were carried out in Wiston over the course of the first weekend in October 2018, and that's when I found out they found a tumour on the pancreas. The process of being referred was pretty swift, to be honest. So from the point of being diagnosed in the first weekend of October, it was a really quick turnaround between referred to the Royal. Luckily for me, it was the best hands I could have been placed in, really. So it was quite a seamless, it didn't feel it at the time, but looking back, it was quite a seamless process of being referred to the Royal here and being assigned a pancreatic specialist nurse, meeting the guy who was going to be my surgeon, who ultimately saved my life. And in terms of being told what was going to happen, the process, the timeline, and the part I had to play was a lot to take in, quite daunting. But the information I was given from the guys was second to none, really. Once you sort of know what's happening and there's a plan, it's fine. But the period in between meetings with the doctors, with the consultants, of trying to find out what's actually happening, that limbo period, it has been in limbo, is mentally draining, really tough, because you don't know what's happening. You don't know if there's a plan, whether you're going to survive, whether you're going to die, whether what they've got planned is going to work. And mentally, that was probably one of the toughest periods. That sort of 4 weeks from diagnosis to the actual operation was incredibly tough. Not just on me, but my family and friends as well. Treatment before, during, and after was second to none. There was a couple of hiccups along the way, shall we say, post-op. But the treatment that I received, and we were talking about major complications post-op, is the reason why I'm able to sit here and talk to you guys now. It was first class, swift, prompt, and very reassuring in terms of the quality of care I received. The surgeons who operated on me saved my life, not once, but 3 times. The nurses within 5C, the ward 5C in the Royal, were all incredible. But if there was one particular member of staff that I've got to take my hat off to, it would be Phil Whelan, who was my pancreatic specialist nurse, who is the most amazing bloke, person, human being I've had the privilege of meeting. He's been so influential in my recovery, physically and mentally. And without him, this would have been a lot different journey than it's been. The challenges that I faced was the information that I was researching myself from Dr. Google, if you like, and then trying to differentiate what the specialists were telling me to what I was looking online. And I think I lived inside my own head for far too long, when the reality was that the information that the specialists and the doctors were giving me, and it was readily available via Phil particularly, was the correct information. Whereas the stuff online, everybody's journey is different. You're reading horror stories that weren't quite relevant. That was the biggest challenge, I think, is trying to keep the two things apart. Life is pretty much the same as it was before the diagnosis. Still go to the match, still eat fairly well, pretty much the same as I used to. Not an awful lot has changed. I think the one biggest difference I've noticed is probably up there, where I'm probably a little bit more paranoid about my health, my well-being than I was before. Before the diagnosis, didn't really sort of think too much about the aches and pains and twinges, whereas now it's probably living in my head a little bit more than it used to. I remember my uncle, who had a non-Hodgkin's lymphoma. We were going to match one day. He went, "Steve, and you've done well to get through this." He said, "But just to let you know, you're going to become completely paranoid about any ache and pain from now on." And I just dismissed it at the time. But yeah, he was right. But thankfully, that's not as bad as it used to be. But that's probably the one biggest change since the diagnosis, really.
Hello. Oh, hi everyone. I'm Phil. I'm a pancreatic nurse consultant. I'm based in Liverpool. I'd only just seen Steve's video, so thank you for Steve, who's become a friend over the years. I actually saw him yesterday as part of a planned follow-up appointment. He's still doing very well, and he wanted to say hello to all the GPs online today. Next slide, please. So just as a very quick overview of the MDT. The MDT runs on a Wednesday morning here at the Royal Liverpool site. We discuss over 4,000 or over 3,000 patients in the main pancreatic cancer MDT each year, plus about another over 1,000 in our pancreas cyst MDT. We also have a separate pancreas benign MDT. So there's lots going on, and we encourage referrals, as Mr. Satsmari's touched on before. Next slide, please. Just a quick touch base on this radiology flag we set up when the trusts, that being Aintree and the Royal Liverpool site, merged in 2022. Unfortunately, we identified some poor practices, and there was multiple serious untoward events which found that maybe patients weren't referred to the MDTs in the correct manner. And we set up a radiology flag for basically any scan that mentions the word pancreas, particularly any problems with the pancreas tends to get sent to us. We just wanted to specify this is not a direct referral to the MDT. We do get sometimes people say, oh, you've got the email, that means it's an MDT referral. We do need more information about the patient, but we do get some really good GP referrals now via these flags. So thank you very much for that. And I triage all our MDT referrals live. I've got my other I've got my email on in the other computer at the moment, so we can always give advice live as well. Next slide, please. So post MDT, the options for patients maybe diagnosed with pancreatic cancer would be surgery, of which obviously that's not possible for everyone, chemotherapy for maybe metastatic and locally advanced cancers, or best supportive care, which really should be standard practice as well with patients who are referred for chemotherapy. So next slide, please. I wanted firstly to talk about kind of the non-operable pathway. So obviously, unfortunately, still most patients diagnosed with pancreatic cancer will die in a short period of time. And over the years, they're the group of patients who I've actually started to try and look after and develop some pathways here in Liverpool. Next slide, please. So many patients are not suitable for surgery, and that's usually because the tumour is locally advanced, so it's around certain blood vessels, even though the surgery now is a lot more aggressive maybe when I first started in 20 years ago. And we've got surgeons like Mr. Satsmari who go the extra mile. Still, a lot of patients are termed non-operable. There's obviously the patients with metastatic disease, patients who are not fit enough for major surgery, and patients who actually don't want to consider surgery. If a patient's not for surgery and they're out of our kind of local area, and the patients will normally be managed by a local upper GI service or hepatobiliary nursing team, and we're really proud to have some really good links with the nurses around the region who we speak to all the time. We get referrals from daily, and I think improving those links over a number of years has benefited from patients across Merseyside and Cheshire. Next slide, please. So if a patient's been basically diagnosed in Merseyside, so maybe the hospital's covering Aintree and Liverpool and the Royal site, traditionally there was no real place for these patients to go. Yes, we had a dedicated pancreatic unit, but sometimes the surgeons weren't really happy to see the inoperable patients, so to speak, as their surgeons, and they weren't operating on them. And was the patient seeing a gastroenterologist? Was the patient supposed to be getting input from the GP about their diagnosis? So I kind of looked at this a few years ago and thought it would be appropriate to maybe set up a separate pathway for patients with non-operable disease. Bear in mind, this pathways for surgical patients are quite slick. The referral pathways post-diagnosis, post-MDT were not as slick for inoperable patients. Next slide, please. So now we've got two clinics across Luft, so to speak. I've got a clinic on a Monday afternoon at the Royal site and Thursday afternoon at Aintree. Patients are identified at the MDT or MDT triage from a non-operable pathway and can be seen in clinic on a face-to-face basis very quickly in a nicer environment than maybe sitting in a busy surgical waiting room for a number of often hours, unfortunately. This is no disrespect to Mr. Satsmari in the Wednesday clinic. So I can see them quicker. I can see them often with a support worker. I can also utilise the clinics for GP referrals with an index of suspicion of cancer, maybe a radiology flag with a dilated pancreatic duct that needs further investigation. So we can tap into those clinics quite quickly, and we can also rationalise the follow-up of some pancreatic cyst patients. Next slide, please. So patients who are for surgery, obviously year by year our numbers have increased, and obviously even during the COVID period, we still had a fully functional unit, and we did many operations, which we're very proud of. So typically patients will get seen post MDT within 1 to 7 days. We have a planning process after the MDT, which is led by myself and our clinical lead, Mr. Barron, where we kind of plan patients' appointments, plan pre-ops, and actually plan surgical dates, often without even meeting the patients, just to try and get our diary filled up and get patients into the system quickly. Looking at last year's figures, between meeting someone for the first time and operation, the median figure was 13 days. And pancreatic surgery is very complicated, but we do have good results. Next slide, please. Mortality in Liverpool, when compared to the national averages, is exceptionally good. Obviously, we can't take away that major pancreatic surgery will also always have a risk of mortality, but it's significantly improved over the years, and our unit is one of the best in the country for mortality and morbidity. Next slide, please. And if a patient has surgery and they get better from their operation, they're normally seen back in a clinic where we discuss their results of an operation, and referral pathways for pancreatic, bile duct, and pulmonary and duodenal cancers would dictate that adjuvant chemotherapy, so chemotherapy after surgery is key. Again, very proud of our averages in Liverpool, that over 90% of our patients recover well enough to have chemotherapy, and compared to the national average, that's about 60%. So with getting patients through surgery, getting patients out of hospital in a timely manner, and then getting referred onwards, often to Cotterbridge for adjuvant chemotherapy. Next slide, please. So after chemotherapy, patients are normally discharged from Cotterbridge. Cotterbridge will often do a CT at the end of treatment, and if they're happy with no early onset of disease recurrence, then they will refer back to a surgical service. Now, I know Kelly mentioned, again, that is the first video I've seen. I was wanted to watch it live about her follow-up, and that's something I've discussed quite a lot with Mr. Satsmari, that we are trying to have more of a nurse-led approach to surgical clinics, and because I do feel sometimes patients are lost in certain surgical clinics based on kind of maybe surgeons' preferences. So what I tend to do, and the majority of patients come through this service now, is a CNS-led service where most patients are seen 3 monthly for 2 years post-op, and then move 6 monthly. That can be a mixture of face-to-face and virtual reviews, and blood examination and imaging, obviously only if that's appropriate. NICE guidance does suggest that there is no real plan for follow-up imaging at set intervals, but as long as a patient has a easy access back to a referring specialist team. Next slide, please. The benefits of having a nurse-led service are we can counsel a patient through red flags, and we can be there on the end of the phone. We can talk about PERT management. We can also foster hope, but also if in the event of, next slide please, patients do having disease recurrence, then that information can be given to them by a team they've already known in a nicer way with a compassionate conversation, and we can then link in with the appropriate community teams and oncology services about further chemotherapy. Next slide, please. So I'm trying to rush through this as quick as I can. So I've run a patient support group since 2015. We usually run that every 3 months, and we have anywhere between 15 and 70 patients who attend the meetings. I get a lot from that. Next slide, please. From that, we've got actually what's called a buddy group. Next slide, please, which actually Steve was a buddy. So he would now come into hospital to meet patients at pre-op that we identify might need some extra psychological support, to give his shared experience. And we've got 5 practicing buddies at the moment who are excellent parts of our MDT. Next slide, please. And very quickly, this is a testament to GPs and radiology flags. This is Chloe, who was 23 when she was diagnosed. She had a very subtle finding on a scan for some weight loss by a GP, which suggested a prominent area at the bile duct. The scan had a radiology flag on it. She wasn't jaundiced. She was sent through to our MDT. The radiologist suggested this was a cancer. Chloe had a small pancreatic cancer removed. Next slide, please. She's had chemotherapy afterwards. She called us up 6 months ago as part of a follow-up, telling me she was pregnant, and now Darla's, next slide, please, is the youngest member of our support group. I could talk about pancreas cancer all day. I've gone over my time limit, but I think the key thing is if you do have any suspect patients in the community, please get in touch with us. Please email us in. We can always triage referrals and give live advice. And thank you very much.
Thank you, Phil. That was excellent. Next, please. So an increasing proportion of patients referred to us are now eligible for surgery, perhaps around 1 in 5, and I would like that to be 1 in 4. Surgery can take the form of a pancreatoduodenectomy or a Whipple procedure, a left pancreatectomy, or a removal of the entire pancreas, a total pancreatectomy. All of these procedures are sometimes done in association with resection and reconstruction of the hepatic portal vasculature, and all can be done open or minimally invasive, so laparoscopic or robotic. We provide the full range of these procedures in Liverpool. On occasion, we will also perform palliative operations to relieve jaundice or bowel obstruction, both of which improve the quality of life, but also are required to commence chemotherapy. As mentioned before, any removal of part of the pancreas will contribute to endocrine dysfunction in the form of type 3C diabetes, which behaves differently to the common types of diabetes you will encounter in your practices. Before I hand you over to Dr. Philip Weston, a consultant diabetologist with a special interest in type 3C diabetes, I would like to leave you with a little ray of hope. Below on the slide there, you can see data from Memorial Sloan Kettering in the USA from last year. I remind you that the 5-year survival for all comers with pancreatic cancer remains between 8 and 10%. Here you can see reported disease-free survival of around 40 and overall survival of around 55% at 5 years in patients who have had surgery and completed optimal adjuvant chemotherapy, which is truly astonishing compared to where we were only 10 years ago. Philip, over to you.
Thanks, Peter. Hi, everyone. I'm Phil Weston. I'm a diabetes consultant at the Royal. Next slide, Sarah, please. And to round off the presentation part of this webinar, I'm going to talk about how pancreatogenic diabetes differs from the familiar with type 2 diabetes and how that difference influences our treatment choices. Next one, please. We've heard already from Peter and from Ethne the complex relationship between type 2 diabetes and pancreatic cancer. And we have a very low threshold for screening people for pancreatic cancer who are diagnosed with what I call unusual type 2 diabetes. Next one, please. We've already discussed the NG12 guidance for screening for pancreatic cancer in people who are over 60 with new onset diabetes. But I would also urge people to look at their existing diagnosed diabetes patients. I saw a patient in a community diabetes clinic last month who'd lived with type 2 diabetes for 10 years, run an HbA1c between 40 and 55 over that time, and was referred to the clinic because his HbA1c, without any change of treatment or any change of lifestyle, his HbA1c had jumped up to 100 plus. He had a little bit of weight loss, and he has triggered the need for investigations of his pancreas. Has he got a pancreatic mass to explain the in inverted commas, deterioration in his diabetes? Next one, please. So why is pancreatogenic or type 3C diabetes different from type 2 diabetes? Well, we've heard already it can often be of sudden onset. These patients are often very insulin sensitive. Because of this, there are increased risk of hypoglycemia, and something that we haven't mentioned at all yet is the impact that exocrine pancreatic failure has, and that is part and parcel of this diagnosis. Next one, please. So if we look at this in tabular form to save time with type 3C diabetes and type 2 diabetes on the right-hand side, type 3C diabetes, pancreatogenic diabetes, these patients are often not overweight. They often have hypoglycemic episodes. They are very sensitive to insulin. And the reason for that sensitivity I'll cover in a moment, but it is particularly because their glucagon, another hormone produced from the islet cells, as you'll remember, is low, as well as their insulin levels are low. And these patients struggle with exocrine pancreatic insufficiency as well. And a lot of our time is spent managing not only the endocrine replacement, but also the exocrine replacement. These patients not only lose weight, they also lose muscle mass. Thank you, Zara. So the hypos are caused by this loss of glucagon protection. You'll remember that glucagon has the opposite effect on blood glucose. The sensitivity to insulin worsens as the weight, or improves depending on how you look at it, but it changes as the weight changes. Patients with more advanced pancreatic disease are often malnourished, and compounded by the fact that they're struggling with malabsorption and exocrine pancreatic insufficiency. And particularly if these patients have had the more invasive procedures and have had bowel anastomoses, that compounds the malabsorption that these patients experience. Because of the malabsorption, it is often difficult to get the timing of insulin right with regards to food. For people with type 1 diabetes, we encourage 20 to 30 minutes pre-eating bolusing of insulin, of fast-acting insulin. That is extremely difficult to do if you have exocrine pancreatic insufficiency or you've had a bypass surgery. And we shouldn't forget, of course, that pancreatic cancer is only one cause of pancreatogenic diabetes, and we see an awful lot of people who live with pancreatitis related to alcohol, and alcohol itself predisposes you to an increased risk of hypoglycemia. Next one, please. I thought I'd just illustrate some of this by showing you some of the blood glucose profiles. This is from one particular patient who was referred. This chap had had a total pancreatectomy 12 months ago for pancreatic cancer. And this is his Libra data. I'm sure you're familiar with these, but on the x-axis is midnight to midnight. The orange line is the median blood glucose over the past 2 weeks. If you look at the box at the bottom and the statistics, you'll see that this patient is spending 20+% of their blood glucose readings are hypoglycemic. And if you look in detail at the orange line, the majority of those hypoglycemic episodes are happening overnight. This patient's only complaint was that he was waking up exhausted because he's been hypoglycemic all night. Next slide, please. So look at the treatments that we're familiar with for managing type 2 diabetes. How do they fit in to manage pancreatogenic diabetes? Well, metformin we still use in these patients, particularly in patients who have not needed advanced surgery or not needed bypass surgery, bowel bypass surgery. But metformin is a horrible drug to take. It often causes GI upsets, and these patients have enough GI upsets. One of the ways metformin works is sensitizing people to insulin, making their liver more sensitive to insulin, so may not be appropriate for a lot of these patients. Sulfonylureas, in the short term, say somebody is in the run up to surgery and we're looking for a quick fix to get their blood sugar down, we may use sulfonylureas, but sulfonylureas are significantly associated with hypoglycemia, particularly in less well-nourished patients. So for long-term management, I don't favour sulfonylureas in these patients. SGLT2 inhibitors, which I'm sure we're all familiar with, are catabolic drugs. They're designed to help people lose weight, designed to help people manage the consequences of their insulin resistance. Often people who live with pancreatogenic diabetes are insulin deficient or relatively insulin deficient, so SGLT2 inhibitors are associated with a real risk of ketoacidosis. So I don't think they have a part to play at all in the management of type 3C diabetes. GLP-1 agonists, as you'll be very familiar, are designed to help people manage their weight as well as their blood sugar. These drugs are associated with malabsorption. They're associated with skeletal muscle loss. And of course, in patients with pancreatitis, there's a risk and a concern that these drugs are themselves associated with pancreatitis. These drugs should not be used in patients with pancreatogenic diabetes. So all that really leaves us with is insulin. And we often end up having difficult consultations with patients, saying to them the only treatment that we have available to manage their diabetes and to manage it effectively is going to be insulin. And as I keep mentioning, we concentrate a lot as well on their digestive enzyme replacement, so the Creona, the Pancreatic. Next one, please. So this is the same patient that I showed you their ambulatory glucose profile before. We managed this patient from their basal bolus insulin. We converted them to insulin pump therapy. And again, in the box at the bottom, you'll now see after 3 months of insulin pump therapy, their hypoglycemia rate is now less than 1%, and particularly in that overnight period. You will, of course, see that the blood glucose profile isn't flat. The majority of the fluctuations that this patient's now experiencing are mealtime related, whilst we continue to struggle to manage the malabsorption and the exocrine pancreatic replacement therapy. But from a symptom point of view, significantly better. So the benefits of insulin pump therapy, we've recently published a case series of 20 or more patients that we've managed with pancreatogenic diabetes with insulin pump therapy. They're associated with lower HbA1c and therefore an increased time in glucose range on their continuous glucose monitoring, significantly reduced risk of hypoglycemia, as I've just illustrated. On pump therapy, we can use more complex boluses to make sure that the timing of the insulin is appropriate for the absorption of the food. And we can see when the blood sugar starts to rise on the continuous glucose monitoring, and that helps us to guide the patient when they should be giving their insulin. And if patients are needing more complex therapies, such as enteral nutrition as part of the management of their pancreatic cancer, insulin pump therapy certainly makes it easier to manage those situations. Next slide, please. What about the future? Well, we are still improving our MDT approach to the care of these patients. You saw from Peter how the pancreatic MDT covers a vast area of Cheshire and Merseyside. We are based in Liverpool, so we can't see all of these patients. We are getting better at screening patients pre-op and pre-intervention for their diabetes and identifying these patients with pancreatic cancers who are diagnosed with new onset diabetes. We're getting better at the pre-op discussions, although not perfect by any means. Obviously, people's primary focus is on getting through the surgery. And as you've heard from our excellent expert patients, managing the health anxiety and the impact of this diagnosis. It often gets lost that they will wake up after a total pancreatectomy dependent on insulin and will have started insulin before the anaesthetic is over. We often manage and have to deal with the impact of the diabetes alongside the impact of the cancer diagnosis. There is definitely a role for technology, particularly continuous glucose monitoring and the use of insulin pump therapy. And we're about to see the era of dual hormone pumps, which I think will be perfect for this population of patients. In America now, there are insulin glucagon pumps. And I think when we get these sometime in the next 12 months in the UK, this population of patients will be ideal for that. Next one, please. So as I say, pancreatogenic diabetes is complex to manage, very much needs a multidisciplinary approach to managing it, which we're improving our multidisciplinary approach all the time. And I think technology, particularly in those patients with more insulin deficient forms of diabetes, technology definitely has a role. Thank you.
Thanks to all our speakers. So we have some Q&As already. If there are any others, please pop them in. And if we don't have time to answer them with you this afternoon, we'll certainly get back to you. Next slide, please. The other area just to mention is evaluation. So we'll keep this slide up whilst we do the Q&A. Evaluation is really important because it helps us as a team and for our speakers to understand the needs of the audience. So please click on that QR code and complete the questionnaire. That'd be brilliant. Okay, so just going through the questions. One from Kaylee Clark. So what do we do for patients who already have type 2 diabetes but have a sudden increase in their HbA1c without a clear cause? So is there a threshold that would warrant a CT pancreas? Because the guidance we have in NG12 only refers to new diagnosis of diabetes. So I don't know who wants to take that one. Is that for you, Phil Weston, possibly?
It's a very good question, and the answer is there are no guidelines, so we have to go on clinical suspicion alone. What we do with these patients, if there has been a sudden change in their HbA1c, and the patient I talked about had a doubling in his HbA1c from the last time it was measured 12 months before. What we measure in these patients, we measure their endogenous insulin production, so we measure C-peptide. Now, there are difficulties measuring C-peptide in primary care because it isn't a shelf-stable hormone. So unfortunately, those patients need to have C-peptide measured, and often the only way of getting that done is by referral to secondary care. And if the C-peptide is still adequate, we would then arrange for CT pancreas. But what is a deterioration in inverted commas in the diabetes is difficult to say because there are no data that we can base these guidelines on.
Okay,
if they're associated with other symptoms, particularly weight loss, I would have a very high index of suspicion of pancreatic disease, and I would arrange a CT pancreas as per Peter's presentation.
Great. Thank you, Phil. So the next one, again from Kaylee Clark. I think, Peter, you mentioned initially looking at weight loss over 50 years of age for an urgent suspected cancer referral. I think NICE guidelines does say 60. I know in Liverpool, certainly we have access to CT only just recently from 50. So is that something that we should be looking at across Cheshire and Merseyside?
Yes, that's quite correct. I think, and the discrepancy, as you quite rightly point out, is between the NICE guidance, which says over 60, and the local Cheshire and Merseyside, which is a Cheshire and Merseyside wide guidance that says greater than 50. So if the referral form still states over 60 with symptoms, then that is certainly something we should look at.
Okay, great, thank you. Another question for Phil Weston, and this is about type 3C diabetes. So if we suspect that in primary care, should we automatically be referring them on to secondary care to confirm that diagnosis?
I would say yes, because I think this is, it isn't the same as managing type 2 diabetes. Mm-hmm. What we'll often do is see these patients initially, often end up initiating insulin because I think it is the only treatment that is going to effectively manage their blood sugars without the potential side effects associated with more conventional treatments for type 2 diabetes. And we would then discharge that patient once stable on insulin back to primary care or back to community diabetes services. That's certainly the policy and the pathway that we try and use in Liverpool. The difficulty that we have is the surgeons are seeing patients from all over in Cheshire and Merseyside, and it's difficult for us at the Royal to see patients who are not from our catchment area. And I think that's something that we're having ongoing discussions with the surgeons about.
Okay, thank you. I think the next question's for you as well. Sorry, Phil Weston, lots of diabetes questions.
How did I guess? I thought there might be.
Does the increasing use of GLP-1 create a potential future issue for diagnosis of type 3C or potentially cause harm to undiagnosed type 3C patients?
Well, I think as GLP-1 agonists in particular become more ubiquitous, and there is certainly a bit of uncontrolled use and access to these drugs outside of the normal prescriptions, I think we are seeing more potential side effects of these drugs. And particularly we're seeing some patients where either with a potential underlying associated cause, such as gallstones, but we're certainly seeing patients with pancreatitis now presenting, and I think that will be associated with longer-term pancreatogenic diabetes. The evidence for them being associated with pancreatic cancer is less convincing. There are certainly animal data when they were first studied that was linked with a suggestion that these drugs were associated with pancreatic cancer. There are no subsequent studies in humans in regular clinical use at regular clinical use doses that have made that association. But I think as with any new family of drugs, and particularly as the use is becoming more and more unregulated, with people getting access through a variety of, shall we say, black market means, I think there is a potential for risk associated with these drugs. I would certainly be very wary if there's any history of pancreatitis, any history of risk of pancreatitis, such as people with gallstones or with alcohol excess. I would be wary of these drugs in those people.
That's great, thank you. We managed to get through all our Q&As. So just with 3 o'clock, we've finished bang on time. So huge thanks to all of our speakers and for people joining us this afternoon. Just a final reminder to complete the evaluation survey, and please remember that the presentations and also the recording of this afternoon's webinar will be on the Cancer Academy. I think that's our final slide. So thank you, everybody.